All right. Well, welcome everyone. I'm sure we'll have more joiners as the morning comes. Um, we um, we are presenting in the middle of the the merging of or the conversion of the ACTG and HPTN meetings, and we are very fortunate that Danielle Campbell is giving us some of her time. And let me introduce Danielle Campbell. She's a fourth-year doctoral candidate and experienced clinical research manager who integrates principles of health equity and implementation science into biobehavioral research, into HIV treatment, prevention, and cure research. She's a member of the research faculty at Charles R. Drew University of Medicine and Science in the School of Medicine, Division of Preventative and Social Medicine. Danielle has expertise in infectious disease-related work, COVID-19, Mpox, and HIV. She's a member of the iStrive Research Lab, where her work examines the influence of structural systems and paradigms of power on the production of health inequities among racial and ethnic and sex and gender minority populations living with and affected by HIV. She has conducted research in biomedical HIV prevention and cure in the intersections of sexual health and systematic oppression. She dedicates her energy to serving as a member of a community scientific subcommittee for a global HIV/AIDS research network and as a volunteer HIV tester counselor aboard a mobile testing unit, and also as an educator and promoter of positive sexual health awareness. She is also a community organizer for HIV/AIDS and sexual and reproductive health, rights, justice, and awareness policies and campaigns. What do you not do, Danielle, is the question. But I guess we will hear a little bit more about the research you are directly engaged in. So I'll turn it over to you and keep an eye on the chat so you don't have to worry about that.
Super. Thanks so much. I do lots of things, but you know. So good morning, everyone. I'm going to be working with two screens. So if you see my eyes sort of vacillate, you'll know that is why. My name is Danielle Campbell, and I am a research coordinator in the Division of Infectious Diseases and Global Public Health. As Jill mentioned, I'm also a super excited fourth-year doctoral candidate in the UCSD SDSU Joint Doctoral Program in Public Health. We're under the expert mentorship of Dr. Jamila K. Stockman. My dissertation will focus on addressing some of the social structural inequities and syndemic factors on willingness to participate in HIV research among Black women. So I wanted to thank the organizers for the opportunity to present today as part of the illustrious High Rounds. My presentation will discuss reproductive coercion as a risk factor for reduced HIV testing among Black women with histories of forced sex in Baltimore, Maryland. I have no conflicts to disclose. And before I jump right in, I wanted to take a moment and acknowledge all of the individuals on this slide for their hard work and dedication to ensure the success of this project, namely Dr. Jamila Stockman, the study principal investigator, and my primary mentor. I'd also like to thank our partners at the Baltimore City Health Department, as well as the Eunice Kennedy Shriver National Institute of Child Health and Human Development for funding support. Most important, I'd be remiss if I didn't thank the Black women of Baltimore, without whom this research would not be possible. Participants dedicate much of themselves to advance our research, and I wanted to be judicious and acknowledge and appreciate that hard work and dedication. So just a bit of background before I jump right in. HIV continues to disproportionately impact Black women. Recent data from the CDC, as you can see here on the screen, demonstrated that Black women, who comprise only 13% of the US population, represented more than 54% of incident HIV diagnoses amongst all women in 2019. That's nearly 2.5 times higher than the rate among white women and 2.1 times higher than their Latina counterparts. specific to Baltimore City, where our study was conducted, data from the Center for HIV Surveillance, Evaluation, Prevention, and Health Promotion Administration of the Maryland Department of Health demonstrated that an estimated 83% of incident HIV diagnoses among women were among non-Hispanic Black women. So you can see the persistence and disproportionate compounding issue that HIV poses on the lives of Black women. And as such, these national and local data demonstrate not only this disproportionate burden as I've described, but really emphasize the need for efforts around prevention, targeting this at-risk population in order to reduce the overall number of new HIV acquisitions. So when we put this issue around disproportionate HIV in Black women into some policy context, right? So the ending the HIV epidemic has been a lofty goal globally, whether it's translated from 95, 95, 95 to this US ending the HIV epidemic framework that was launched in 2019 by the US Department of Health and Human Services. Essentially, the policy frameworks aim to reduce new HIV diagnoses by 90% by 2030 by scaling up these HIV prevention and intervention strategies. One of those strategies is to diagnose. And so the effort is to diagnose all people living with HIV as early as possible, and then enter them into this cascade for treatment, which means to, which aims to treat those individuals who are entered into this diagnosis cascade with rapid and effective antiretroviral therapy to achieve sustained viral suppression. And then concurrently, you want to consider those individuals who are not diagnosed with HIV and prevent new transmissions of HIV, all wrapped in this conversation to end the HIV epidemic by 2030. So as someone who dedicates her work to examining some of these systemic and structural factors, power differentials that really negatively leverage health outcomes among Black women, we have to peel back the onion just a bit to understand what some of these factors are that keep HIV well embedded in the lives of Black women. So back to this early testing HIV pillar, right? This diagnose framework. The CDC suggests that everyone between the ages of 13 and 64 get tested at least once as part of routine care. And there's also a caveat that people with certain risk factors get tested at least once a year. For Black women, we receive a higher percentage of late-stage HIV diagnoses than our white counterparts. And additionally, if done well, early HIV testing can support reductions in secondary transmissions to sexual partners. So it's part of this dynamic to reduce HIV diagnoses in communities, to keep folks virally suppressed, to prevent secondary HIV transmission. However, Black women, for some reason, are either not testing, right, which is why we receive these late-stage diagnoses much more at a higher rate than women of other racial ethnic groups. And so we have to consider all of the things, as I mentioned, that support this 1 in 48 lifetime risk for HIV among Black women in comparison to other racial ethnic groups of women who experience HIV in their lifetime, and 1 in 399 for white women, and 1 in 227 for Latino women. So we got to do something, folks. We got to do something if we're going to improve some of the HIV outcomes among the Black women population. We want to leverage strategies that support culturally tailored testing approaches in this group. So as I mentioned earlier, my research looks at some of the social factors, the structural factors, and the syndemic conditions that intersect with HIV. And so reproductive coercion is one. So reproductive coercion fits within this framework of sexual violence. And for Black women, it's an established factor for adverse mental and physical health outcomes that affect HIV acquisition. And so just to give some additional context, reproductive coercion encompasses verbal and physical acts perpetrated by a male partner that interfere with his female partner's reproductive autonomy. And I'm not sure if folks are paying attention to what's happening in the zeitgeist. The attacks on women's reproductive freedom and just the attacks on people's reproductive freedom are rampant. And I'd like to note the recent Supreme Court decision to keep mifepristone, I think I said that right, yeah, mifepristone, a medication that is used to support abortion on the market. So it's a win, and a win is a win. So yeah. So for Black women, the lifetime prevalence of reproductive coercion among women in the US is estimated at about 8.4%. But when you put that into context for Black women, again, it's much higher at about 22.9%. And when we take it more granularly to the Baltimore context, reproductive coercion among Black women is about 37.8%. These comparisons are staggering when you talk about the impact of reproductive coercion or sexual violence as it intersects with HIV acquisition. And then if you reconsider that 87.5% of new diagnoses amongst women in Baltimore are among Black women. So we start to build a story. Violence follows HIV acquisition in this context. HIV testing could be a framework to circumvent new HIV diagnoses, provided Black women are being tested more frequently as part of routine care, as recommended by the CDC. But we see that that's not happening. So today's secondary data analysis is brought to you by the Essence study. And so the Essence study that was conducted by Dr. Jamila Stockman at UCSD, Dr. Danielle Campbell at Hopkins, is a super awesome study that had 4 aims. And it aimed to examine the association between features of the built-in social environment, forced sex, and other HIV risk factors. It aimed to determine the physiological effect of recent or chronic history of forced sex on the stress response. It aimed to assess whether features of the built-in social environment and psychological factors moderate the relationship between forced sex and HIV risk factors like unprotected vaginal sex and a recent STI. And then lastly, to qualitatively elucidate the effect of the built-in social environment's role on increasing one's likelihood of experiencing forced sex and a woman's perception on stress related to forced sex in relation to sexual risk behaviors. And what you see here in brief are the domains of inquiry that were included as part of the Essence study. So all things considered, I thought it a super awesome idea to conduct a secondary analysis aimed at examining the association between reproductive coercion and HIV testing among Black women with histories of forced sex, given the phenomenal presence of reproductive coercion amongst this population of women. And so I hypothesized that women with forced sex histories would have a lower odds of HIV testing within the past 12 months. So just a bit on my methods. So for the Essence study, it was a retrospective cohort mixed method study that was conducted in Baltimore, Maryland. Between 15 and 18, Black women were recruited from Baltimore City Health Department's STD clinics. And if women completed the eligibility screener, they got $10. if they completed an on-site quantitative survey via a CASI, they got an additional 25. To support the fourth and final aim of the study, there was a salivary cortisol self-collection kit that women were handed, and then the study was approved, as I mentioned, by both Johns Hopkins and UCSD IRBs. So a bit on eligibility criteria. Participants had to identify as either Black or African American, be assigned female sex at birth, be between the ages of 18 and 44, report having been in a sexual relationship with a male partner in the past 6 months, report one or more of the following risk behaviors in the past year: 2 or more sexual partners, and or sex with a high-risk male partner, someone who identified as MSM, someone who had been incarcerated, injected drugs, etc. And so for the purposes of this study, the exposed group included those individuals with forced sex experience. And that included, sorry, my pointer. And that included those individuals who had experienced sexual assault by a man since the age of 18 via physical force. And that encompasses being hit, held down, someone used a weapon, or threats thereof of any of these types of behaviors. So for this study, my dependent variable was past month HIV testing, and I created a dichotomized variable, whereas my independent variables were reproductive coercion victimization. And I measured that using the reproductive coercion scale. It's a 9-item measure to assess participants' experiences with reproductive coercion using a dichotomized response. And then the Cronbach's alpha was 0.89. And some examples from that questionnaire included: has a partner ever told you not to use contraception? My other independent variable was reproductive coercion perpetration, which is really, really significant because oftentimes when the literature contextualizes reproductive coercion, it is often from this victimization framework where we look unidirectionally from the male partner to the female partner, but it does not look in the reverse at the female partner and any acts she can perpetrate against her male partner. So we flipped the camera a bit and looked at bidirectionally how these experiences, either by victimization or perpetration, affect HIV testing amongst this group of women. So to measure reproductive coercion perpetration, I used a different scale of the RCS, and it's an 11-item measure used to assess abusive behaviors enacted by the participant using this dichotomized response option. And then the Cronbach's alpha really well was 0.87. And so just some of the response options were things like: have you ever told the partner you would have a baby with someone else if they didn't get you pregnant? And then my covariates for the analyses included age, sexual orientation, current employment status, current relationship status, and lifetime pregnancy history. So my analysis included only women with non-missing data. They were performed in our studio. I'll describe some of the descriptive statistics and also the results from the binomialistic logistic regression models that were used to examine the association between reproductive coercion victimization, reproductive coercion perpetration, and past 12-month HIV testing as a dichotomized variable. So here are the results. Okie doke. So the demographic characteristics of my population are as such. On average, participants were really young. They were on average about 28 years of age. They were well educated, at least 3/4 of whom had a high school education or more. 2/3 had an annual household income less than $10,000. Rates of reproductive coercion victimization amongst the sample were higher than the national average. 27%, and that's in comparison to the 8.4 national number, had a lifetime history of reproductive coercion victimization. 12% of study participants reported reproductive coercion victimization in the past 12 months, while 19% reported a lifetime history of reproductive coercion perpetration, and 11.4% reported this experience in the past 12 months. So lots and lots and lots of sexual violence committed, not only from the male partner to the female partner, but from the female partner to the male partner, which was an outstandingly surprising finding. So results from the logistic regression model. Here you'll see the results of my logistic regression model assessing the relationship between RCV, RCP, and past year HIV testing amongst this sample of Essence participants with histories of forced sex. So women's with histories of forced sex and experiences of past 12-month reproductive coercion victimization at the end of the day had a decreased likelihood of HIV testing. However, I could not identify any statistically significant associations, even though the odds ratio supported the directionality of the odds ratio supported my original hypothesis. But we didn't give up. So as I mentioned, there were no, although I didn't find any significant associations between reproductive coercion victimization and HIV testing, as I mentioned, the odds ratio was in the direction that I had originally hypothesized. And I suspected that the sample size was, for these analyses, was too small to detect any significant associations. And then to put that into context, additional qualitative research may be needed to understand how these trends affect the lives of women with these unfortunate experiences. And I would not be a public health practitioner if I did not discuss the public health implications of these findings. At the end of the day, public health clinics have a unique opportunity to provide culturally tailored services for women with experiences of violence. There is an opportunity here, and that these high rates of reproductive coercion and reproductive coercion victimization and perpetration highlight the need for more trauma-informed care in sexual health clinic settings. So with that, I can stop there. My contact info is on the screen if you'd like to hear more about my research that I can talk about all day. I can stop there and kick it back over to you, Dr. Blumenthal.
Thanks. That was nice and short and tight, and we like that sometimes, which should leave us ample time for discussion. I will open it up, but if no one looking around, there was nothing in the chat. I can start with a question. You used cortisol salivary collection as one of the measures of stress, correct?
Yes.
How did you decide on that? And can you, like, as a clinician, it's not something that I typically measure. And I'm not saying that it should be something that we use clinically, but what was the decision to use that as a measure? And are you using anything else as an objective measure of stress?
So I will say that the researchers chose to utilize this specific measure of stress, as the literature supports, to determine the physiological effect of a recent or chronic history of forced sex on this stress response within the HPA axis. It's represented by this pathway called the cortisol awakening response. And so to measure the effect of stress on that response, you measure cortisol via saliva. And so at this, as part of this cross-sectional study, participants collected these saliva samples, and the results will be out very soon to say more about what they told or the stories they told from participants.
Very interesting. And I see Darcy has her hand up. Just one other question, because I remember seeing some of this work or some preliminary work a bunch of years ago. And there was the thought was to use C-reactive protein, a serum C-reactive protein. I don't know if that's something that's still being used, or I mean, obviously just checking, getting a salivary cheek swab or whatever that is obviously very easy, whereas getting a serum CRP involves a blood draw. Are there other markers being used, or is that what has been sort of decided upon based on literature?
Yeah, that was decided upon, and budgetary constraints considered, right? A blood draw is something quite different than a self-collected saliva sample.
Okay.
Yep.
Very cool. Thank you. Darcy.
Thank you so much for sharing. This is really awesome. I apologize for this question in advance because it's not directly related to your study or the research that you're doing. My role is in education and training future ID physicians and ID physician scientists, many of whom will, work with patients like the ones in your study. And I think as physicians or even as researchers, a lot of these issues that we see in day-to-day practice are related to systemic and structural factors. And I know there's been a lot done in terms of training people to be better skilled in trauma-informed care. But I think at the end of the day, a lot of the root causes are things that need to be addressed from a policy level, from advocacy. And so I'm just wondering kind of what your perspectives are in terms of what type of education and training should we be giving to future physicians, future researchers in terms of advocacy skills and ability to impact policy? And is there a role for us in that space, or should that be, left to other groups, since most of what we do is, one-on-one, but we still see the impact on these kind of system level things where we might want to make interventions. And so I'm just wondering kind of what your thoughts are there in terms of how do we train people to be advocates beyond kind of what they do in their patient care and or research?
That's a really great question. I think there's so many ways we could approach the conversation about how we can empower physicians to be better advocates, right? So there's one conversation that physicians and other healthcare providers are gatekeepers to different healthcare considerations in Black women. So I read a study that demonstrated if Black women don't have trust in their healthcare provider, if they experience racism or discrimination by a provider, then they become disengaged in the healthcare system. So that puts the onus on the provider to check privilege, to check explicit and implicit bias, to support a more sustained and pleasant healthcare experience for Black women. That's one. So when we talk about what can we do, training is one. I've seen lots of training paradigms come down the pipeline around implicit bias, cultural appropriateness in the context of the healthcare setting. It's really about self-awareness and understanding some of the historical context and abuses that medicine has perpetrated against people of color, and how it facilitates a lack of engagement across public health issues, especially as it relates to HIV. So it should start with some self-reflection, and that could be getting involved with local advocacy groups. I know that some schools of medicine have patient advocates who come in, who are part of scenarios that you all use in the teaching framework. As part of that, incorporate conversations from the lived experience of some of the patients that you'll serve to better provide clinical care to your patients. So that's one. Get out on the front lines with us. Stay involved in what's happening on the policy front. There's a ton of things happening around reproductive health that you all could get involved in. And it's not just coming out on the front lines, being directly involved in policy efforts, but it's really playing your part in providing this culturally tailored healthcare to people, taking into consideration our lived experiences and how they may affect either negatively or positively our continued engagement. So I hope that makes sense.
Yes, thank you so much.
And I see that Dr. Stockman is on. She could also add some additional insight. Jill, your question was a great one. I had to go back to my notes, but Dr. Stockman's on so she could talk about other things.
I think you answered that beautifully. But if Dr. Stockman would like to say anything else or share anything about, I know this incredible work she's been doing for a while, and
Fabulous.
I know everyone's very busy. Oh, there she is.
Thanks, Jill. Amazing job, Danielle. Great work. I'll just add on. I have to hop off, but I'll add to the response Danielle provided regarding I think the question was if there were any considerations to use additional biomarkers in addition to cortisol. And so, yes, so for this particular study, we did have budgetary limitations. So we went with cortisol. However, we extended upon this research with a subsequent case control study focused on survivors of sexual violence, specifically rape, within the past month, and to understand their HIV susceptibility over time. And for that particular study, we utilized, in addition to measuring the cortisol awakening response, we had measured additional biomarkers such as C-reactive protein, ACTH, cytokines, to understand systemic and local genital immunity. So we were able to expand upon this smaller sample size in that particular study, but a more robust collection of additional biomarkers. And so analyses of that study is underway, and publications forthcoming.
Thank you, Dr. Stockman.
Very cool. Thank you. I have other questions, but I don't know if others want to ask. I know this is taking place in Baltimore, this particular study, and I feel like iStrive and other work is happening, like it's happening all over. Are there other sites? I don't know if this was a particular study or if there are, multiple sites doing similar things. Or was this for, a particular call and it's centered in Baltimore?
As far as I know, yes. It was just the call for the Baltimore STD or the public health STD clinics. Dr. Stockman, were there plans for other sites as part of Essence? Or was it
Not part of Essence. For the subsequent study that I had mentioned, that was locally based in San Diego. So Baltimore was selected for Essence just because it fit the bill in terms of the disproportionate burden of HIV and forced sex at that particular time, and immediate connections to the city health department STD clinics. So we had already established collaborative relationship. So it was very easy to pull together a grant proposal within that 6 weeks turnaround time for the RFA.
Anyone else want to share or ask? Otherwise, we can, I'm just making sure I didn't miss anything. Otherwise, we can give Danielle back to the ACTG meeting. In the HPTN meeting. I'll just give it another minute. No, yeah. You really do such incredible work, and I think I got a couple of messages privately, what great passion and enthusiasm Danielle has. And if anyone knows Danielle, that's it's just like it's built in there. So anyway, it's wonderful having you talk and share the work that you're doing. We really appreciate it.
Thanks so much, everybody, and have a great day.
Bye, everyone. I believe we'll see you next week.
Yeah, we want to do Dr. Riley Cares is going to be doing hybrid, so she's going to do something in person. So hopefully, if you have the time, please come to the AVRC.
Bagels, right? Or donuts or something.
We might get snooze.
Oh, snooze.
So that's what.
Does that mean there'll be like pancakes and stuff?
like some savory stuff, savory and sweet stuff. So
okay,
I think that's what we're working on. It'll be a treat.
What's snooze?
Yeah.
It's like a great brunch.
I don't get out.
Yeah, it's really, I think it originated in Hillcrest, right? Brunch
I think they're actually from Denver.
Now. Oh, it's from Denver?
They're based out of Denver.
Got it. But a really fun brunch place, and they've got a very lively spot in Hillcrest. Always lots of people outside, and I think they now have like cornhole boards outside on the street. Anyway,
Really?
All right. Well, everyone, hopefully we'll see you in person next week.
Thanks.
All right. Enjoy the conference. Bye, everybody.
Bye-bye.